audience. My name is Peter Forsberg. I'm an assistant professor at the University of Colorado. I'm a plasma cell disorders specialist, so I'm excited to learn about lymphoid malignancies from our wonderful panel of experts today. We really have a world-class group of providers here to share information on a number of interesting cases. So I'll ask them to introduce themselves. Dr. Pagel.
I'm John Pagel. I am not a plasma cell specialist. I actually focus on lymphoid malignancies, really exclusively do research and, of course, patient care in lymphomas and CLL, and I'm at the Swedish Cancer Institute in Seattle, Washington.
Hi, I'm Michael Thurman. Thank you very much for inviting me to participate in this tumor board. I'm on the faculty at the University of Chicago, and I specialize in lymphoid and myeloid malignancies.
Pleasure to be here again. Thank you. I'm David Schuster, and I'm a radiologist. I'm Division Director of Nuclear Medicine at Emory University in Atlanta.
So this is a 40-year-old male with newly diagnosed advanced stage classical Hodgkin's. And we're going to focus on a few different questions on this patient's case, including what our favorite approach is, how do we approach lung toxicity and infection risk in making decisions regarding frontline therapy, and also how do we consider best PET-adapted approach. So we'll try to tackle all of those. So this is a patient who presented with a 6-month history of progressive neck adenopathy and 2-month history of pruritus, fatigue, and night sweats. No other significant medical history. We don't know their social or family history, so likely non-contributory. So in this young patient in 2021 underwent imaging, which we'll have Dr. Schuster describe for us.
So here we could see a large mediastinal mass. There's also mass on the right as well. We also have upper abdominal and retroperitoneal nodes and axillary nodes. And I believe there is also skeletal lesions as well. So this is stage 4 disease.
So in addition to adenopathy above and below diaphragm, this mediastinal mass and axial involvement, they went ahead and did an excisional cervical lymph node biopsy, which demonstrated classical Hodgkin's lymphoma. Additional labs demonstrated a white count of 12, hemoglobin of 10, and an ESR of 45. So with that in mind, I guess our first question will be, I'll ask Dr. Thurman, so what would your favorite option be for this patient's treatment?
Well, so this is an interesting case, a relatively young individual presenting with advanced Hodgkin's disease with high-risk features. We don't have all the information available here in terms of assessing the IPI score for him, so we don't know the albumin, for instance, but he is anemic. His hemoglobin is 10, so that would give him an extra point on the IPI scale. Males have an extra point. His white blood cell count is slightly elevated, but doesn't hit the cutoff of 15,000, and we don't know his lymphocyte count. But suffice it to say, he is at high risk, although having said that, there is a high likelihood of cure. In general, in the US, we've used the ABVD regimen for a long time. The Europeans favor escalated BEACOPP as an alternative approach. And so either one would be acceptable. And we typically use PET to help us guide therapy to determine whether or not the patients are responding well to treatment and whether we need to either escalate or have the possibility to de-escalate therapy.
Yeah, I agree with Dr. Thurman. The standards, of course, have been ABVD-based therapy, and we certainly understand the RATHL data. That data suggested to us that, in fact, in many patients, we can remove bleomycin from the regimen with a quote-unquote negative PET scan after 2 cycles. Another option for this patient, and probably would be my favorite option, would be the use of brentuximab vedotin with not ABVD, but with AVD, taking out the bleomycin. And that regimen, we also call it AAVD for Adcetris AVD. So AAVD was shown in advanced stage patients, many of them very high risk, that there was a 5-year progression-free survival advantage for those who got AAVD over those who got 6 cycles of ABVD. And actually the plateaus on the survival curves out at 5 years really do suggest that these patients will probably have a statistically significant increased rate of cure at 5 years with AAVD versus ABVD. It is important to understand that it comes with some costs. So there's, of course, a concern about peripheral neuropathy, and there are cytopenias that are significant with the Adcetris-based regimen. And so you do need to use growth factor support, and you do need to obviously watch for febrile neutropenia and infections. But I think that's another option for patients that we should consider as well.
Dr. Baker, would the patient's age and sort of comorbidities push you in a specific direction regarding the decision between ABVD, PET adapted, or AAVD?
Yeah, it's a really good question. I would say for me, with any advanced stage patient, I'm really personally won over by the 5-year survival data that I just mentioned, even if, and especially perhaps in people who are younger. That one of the more interesting things that also came out of that frontline trial using AAVD versus ABVD was that there were 1/3 less patients who had to get an autologous transplant if they were randomized to the AAVD arm as opposed to the ABVD arm. So you're curing more people up front. That doesn't mean that if you got ABVD and you relapsed, you couldn't be cured with a transplant. But I think really overlooked in large part, especially for a younger patient who you want to avoid all that morbidity and potential for secondary malignancies, 1/3 less of them having to get an autologous transplant is quite important as well. So the age actually even probably in many ways pushes me a little further to use AAVD over ABVD for this patient myself.
Dr. Thurman, any thoughts about the second question about how lung toxicity or infection might factor into decision regarding frontline therapy?
Well, I think if there's any hint of any lung toxicity, then I would certainly go with the AAVD over ABVD to avoid the bleomycin. And conversely, if a patient had any neuropathy, I would avoid the AAVD regimen where there is a higher incidence of neuropathy. So I think underlying comorbidities are critical to that decision. And the other thing I would like to point out is that you do have an option of switching if a patient develops a drop in their DLCO on ABVD. You can switch at that point. Or if the patient's developing neuropathy, you could make a switch to bleomycin. So it's important to monitor the patients during the course of their treatment and make adjustments as necessary.
Well, so then in this circumstance, to summarize, we have a young patient who has a new diagnosis of classical Hodgkin's with high-risk features. In this setting, we still, have good approaches to target a cure, and that our two main considerations would be ABVD with a potentially PET-adapted strategy versus AAVD. Both with potential for good outcomes, some potential to stratify treatment approach based on patient characteristics and comorbidities, but with either, in particular with AAVD, with monitoring for specific toxicities and the need for GCSF support to help minimize risk for toxicities along with.